share my experience on this spiral tenodesis of the wrist. And for this particular case, it's very unique because there's the indications for this are very, very strict, and only certain cases then they are appropriate. Then only do we consider doing this technique. So I would like to just share with you my experience. All right, I want to pay tribute to Dr. Mark Gracia-Ellis, who is actually my mentor, and also we were both instrumental in actually discussing and coming out with this technique during his visit to Singapore some time back. All right, so back in 2006, we had this tri-ligament tenodesis for the treatment of scapholunate dissociation. I shan't elaborate on this because I think my previous speakers have already spoken in part about these, the indications for this and the options for scapholunate reconstruction. Right, so for patients with chronic scapholunate dissociation with concomitant undiagnosed extrinsic ligament injuries, if you just go ahead and do a scapholunate repair or even a reconstruction without dealing with all these ligamentous injury, you actually have this failed repair or reconstruction because you haven't addressed all the other stabilizers which are actually non-functional. So it's like trying to get this thing, trying to build a house on unstable foundation. I'm sorry, I can't advance a slide. So we introduced the spiral tenodesis to address this issue, right? So why spiral? As illustrated by my previous colleagues who mentioned that if you look at the wrist, when the carpet is loaded, right, the distal row goes into pronation and the triquetrum goes in extension. Concomitantly, the scaphoid is into flexion, and the lunate will actually tend to translocate ulnally. I'm sorry, but the slides aren't advancing. I'm trying my best to sort this issue. Can you see my screen, Juyap?
Yes.
Yeah, but it's not advancing. I'm so sorry about it.
Yeah, it's not going.
Yeah, so what are ligaments that are constraining the displacement? As you can see, right, first of all, you have a dorsal scapholunate ligament, right, and followed by the scaphocapitate, the dorsal intercarpal ligaments, the dorsal lunotriquetral, the volar lunotriquetral, and the long radial lunate, as well as the radial scaphocapitate. All these ligaments, as you can see, form a spiral configuration around the wrist, thereby providing the stability for the wrist during loading. Okay, so these are all the ligaments that are working in conjunction. So it's not just an isolated scapholunate ligament that is holding on to the scapholunate joint axis, but rather all these ligaments surrounding it, providing stability to both the scapholunate joint as well as the wrist as a whole. So what are the surgical techniques? We actually did a cadaveric testing, right, with this reconstruction. We found it to be very stable in both flexion extension as well as pronosupination. So in 2012, we published this technique on spiral tenodesis using the FCR as the main tendon graft for reconstruction. And in 2017, Sanjeev Kaka actually modified by using an ECRL tendon, which we also adopted it after that. The reason being the ECRL extends and supinates the scaphoid better than the FCR, because we also want to preserve the FCR because it's an important scaphoid stabilizer. And the ECRL has a longer tendon length, 14 cm compared to FCR, which is 11. My apologies, but the slide seems to lag. All right. So, so this is essentially what happens when we harvest the ECRL, and then we bring it forward to the front of the SCT, and then we create a scaphoid tunnel from the scaphoid tubercle to the dorsal ridge of the scaphoid, and then we pass the tendon through to from volar to dorsal through the tunnel, and as it emerges out, it straddles the scapholunate joint, and from there we then stabilize with 2 K wires at the scapholunate joint once we reduce the SL joint, and then we create a tunnel at the triquetrum, and then we put in the free edge of the graft through the triquetral tunnel from dorsal to volar. And also we stabilize the lunotriquetral joint with the K wires. And then from the volar, we then pull onto the tendon. The tendon is actually just at the volar aspect of the carpus, deep to the flexor tendons. And we anchor it at the radial styloid. So you can see from the transverse view, right, the ECRL tendon goes to the front through the SCT ligament. Okay, travels through the scapholunate tunnel, through the scaphoid tunnel to go dorsally. And then once we reduce the scapholunate joint by pulling on the free edge of the graft, we then secure with the 2 K wires the scapholunate joint, insert a bone anchor over the dorsum of the lunate. Is exactly the same as the 3LT procedure up to this point. Then, of course, the addition of triquetral tunnel, right, to pass the graft from dorsal to volar, stabilizing the lunotriquetral joint, and then of course we anchor the edge or free edge of the the tendon graft into the radial styloid. Okay, you can see we have restored the spiral configuration of all the associated ligamentous restraint. So the indications of spiral tenodesis is very, very specific for patients with a chronic perilunate instability with the following: complete irreparable rupture of the SL ligament complex, secondary stabilizers that are insufficient or torn, and the lunate is unstable, where it translocates ulnarly or grossly malaligned from the loss of the ligamentous restraint. And the carpal misalignment is easily reducible, and there's no articular cartilage compromise. All right. So whatever I've discussed so far is on the open procedure, but we actually have the arthroscopic option, thanks to our European colleagues, Dr. Andre Atse, as well as Dr. Mireya. Right. So this arthroscopic option allows this very, very technically challenging procedure to be done arthroscopically, right? So these are the various portals that we use to perform the surgery. And we can also see additional portals, and as well as the incisions that we make volarly as well as dorsally to enable us to perform this minimally invasive option. Okay, we have to drill the triquetral tunnel, and then we have to drill the scaphoid tunnel, and then we create suture loops, right, to pass from different portals so that we can actually assist in getting the ECRL graft to form a spiral configuration around the carpal bones, just like the open procedure. Okay, so the suture loop does this function. So once we get the suture loops deployed and in place, right, then we harvest the graft, and then we start to perform the procedure. So when the graft, again, once it goes volarly, it goes through the scaphoid from volar to dorsal, then it goes across the SL as well as the LT joint, and that will straddle the DSC ligament dorsally. And then once you get the free edge of the graft that comes out over the ulnar aspect, then it goes through the triquetrum dorsal to volar, and then across to the radial styloid, straddling both the long radial lunate as well as the radial scaphocapitate ligaments, and all with the help of the suture loops that are pre-placed to deploy the ECRL graft. And these are all the suture anchors as well as the interference screws at the location shown below. So you will recreate the following: the DIC, the dorsal scapholunate ligaments, the volar LT, the long radial lunate, as well as the radial scaphocapitate ligament, forming again a spiral configuration around the carpus to act as a restraint for pronation torque during loading. So what are the advantages of this arthroscopic procedure? It's less traumatic, as what my previous speakers have mentioned, right? Most of the joint capsule well preserved, so there's no compromise in terms of vascularity. And the important thing is that the posterior interosseous nerve is not sectioned. There are no K wires to splint the joint. You notice that this arthroscopic procedures, there's no K wires that's inserted. So this will allow early mobilization, right? So in summary, when the wrist is loaded, there's inherent distal carpal root pronation. The scaphoid flexes and the triquetrum will extend. The lunate will tend to translate ulnarly. So competent wrist ligaments form a spiral restraint to counter the pronation torque during loading of the wrist. So in some chronic perilunate instability, they result in a situation where there's a complete ligament rupture of a scapholunate, as well as associated secondary stabilizers with unstable lunate. So spiral tenodesis is a procedure that will address this form of instability. And the prerequisite is the carpal misalignment has to be easily reducible with intact cartilage. And failure to adhere to these strict indications will actually render this procedure ineffective. So that's an important point to note. An arthroscopic option has been developed and should be published very soon. With that, thank you.